In this video, we're going to explain to you all the parameters that we hope to collect for the restore trial. We're providing this interpretation by a picture, and we also have an Excel-based collection tool, which I think you'll find useful, and I'll go through in the second part of the video. But first of all, I'm going to go through each of the parameters and how you collect them. The one most familiar to us all is, of course, the Haller index. You need the largest internal transverse diameter, T, on this picture, and it should be a totally horizontal line when you collect it. And then AP min is the smallest distance you can find when scrolling up and down. Doesn't have to be underneath the zippy sternum or sternum. It can be cartilage or soft tissue, and it's from the very lowest point to the point parallel to the front of the vertebral body. Sometimes it won't be directly over the vertebral body, it'll be to the side, but so draw a horizontal line on the front of the vertebral body to make sure that you can do a vertical line down to measure this. And then the calculation is simply T over AP min. A very important issue is that we really want CT scans, if possible, in expiration, end expiration, and end inspiration. And this diagram shows why. The Haller index is very markedly different in expiration and inspiration. And actually, I think that the difference between expiration and inspiration might in itself be an important parameter for how severe your pectus excavatum is. Now, because it is so important, we're going to collect all the parameters in inspiration and expiration if your radiologist can provide those images. So apologies, but I do think it is going to end up very important, and we really need to make the prediction of who benefits most from surgery as good as possible, and I think the CT scan is key. So I hope you'll support us in trying to get end inspiration and end expiration images. Now, if you can't, just make sure you've annotated it correctly and submit to us the correct phase of measurements. We've come to realize that actually the Haller index is a very poor measure of severity of pectus excavatum, and we'd like to therefore collect three much better indices. The next most common index is the correction index, and as you can see here, it takes AP min, the minimum distance, but instead it uses a vertical index of basically where the sternum perhaps should be, AP max, and it's a proportion of these. So if AP min is half of AP max, your correction index would be 50%. And in my head, the correction index is what percentage of elevation is required to have a normal chest. Now, the advantage of this is that it's independent of the width of your chest, unlike the Haller index, and therefore should be a better index. Perhaps an even better index than the correction index might be the vertebral index, because some people have very asymmetrical chests, and the most independent of either width or height of the sides of the chest is something called the vertebral index. The vertebral body is very well correlated to your height and size, so therefore perhaps if we have a vertebral index which is AP min as a proportion of the vertebral diameter measured anterior to posterior, then this might be even better to correction index, and several papers have documented this. So we're going to collect the vertebral index because it might be superior to the previous two indices. And the final index of severity that we're going to take is actually the one used at the Mayo Clinic in Phoenix and the one most favored by their radiologist. He feels this is most significant for patients and most correlative with a person's benefit after surgery. This actually is the only one to take the severity of the dip. Now, very importantly, how do you measure the dip? Well, you take the highest line, which is the most anterior-most point of either the ribs or cartilages between the left and right chest, and then you measure down to the anterior table of the sternum, not posterior, anterior, either of the sternum or cartilages. And then again, this uses the very independent measurement, which is the measurement of a vertebral body, because that's very correlated to your height, but actually for some technical reasons, it uses the lateral horizontal diameter of this. So we're going to use this because it correlates to the Mayo and Phoenix. That makes 4 indices of severity and inspiration and expiration. And I think this will allow us to really determine who benefits and doesn't from surgery. So I hope that's okay for you. They're actually quite quick to measure, as I'll show you when I go through some examples. And I hope I have your support measuring these, hopefully in inspiration and expiration. So we thought we'd measure an asymmetry index because it's very simple. It's just the largest vertical internal diameter on the left over the largest internal diameter on the right, just because we think some of those other indices work relatively well if you're not that asymmetric, but work terribly if you're asymmetric, especially the correction index and the Haller index. So I think it's a very easy measurement to make, and I think it is going to be useful to measure how asymmetric our patients are. Also, the correction can be more difficult, so might be a measurement of difficulty of the procedure. Very easy to do, and again, we'll give you some examples of how to measure it later. And the final measurement of the actual chest cavity is just the torsion angle. What's the angle of the sternum? Very easy to do. So just a quick angle and the direction of the angle. The measurements we're hoping for you to collect are in 3 parts. Firstly, the chest cavity, which we've just covered. Secondly, the cardiac heart parameters. And thirdly, a vertical measurement. So this is the second part. And this, I think, is super important, the cardiac compression index. NHS England will allow NHS surgery even now if we can prove that there is cardiac compression on CT scan or equivalent imaging. So actually we need an index, and we're not collecting this at the moment. So there's a very well agreed and validated score called the cardiac compression index. So I call it the Haller index for the heart. And so it's the horizontal widest diameter of the heart, which is H in this image above, over the minimum distance. So now this is the minimum distance of the actual heart. We'll give you a few examples a bit later, but basically we would like this to be just measured from the front of the heart to the back of the heart, not all the way to vertebral bodies. It's cardiac tissue. Also, as we are going to show, you should really have at least 1/3 of the atrium in this measurement, because sometimes hearts are so squashed across, they're actually not even under the sternum. So we do need to move this measurement across to have some of the heart in it. And we're recommending at least 1/3 of the atrium in it. The second cardiac measurement is called the cardiac asymmetry index. This is basically how circular is your heart. If your heart's a proper circle, this will be 1. It's also a very simple to measurement. You only need one more measurement, which is P in the diagram, which is the highest vertical point of the heart, usually the ventricle, from front to back of the cardiac structure. And so we've now done 2 out of the 3 main areas that we're going to measure. So chest cavity, heart itself, and then the final one is just one measurement of the vertical amount of depth of compression, because we don't have any other measurements for how high up the sternum is compressed inwards. So, because obviously we have things like platithorax and very large compressions, and sometimes it's just the very bottom of the sternum that's compressed. So we've chosen one measure of how much of the sternum is dipped in, and it's called the Titanic index. So this index is basically what proportion of the sternum is dipped below what is called the anterior costal line. Now, the anterior costal line is taking a line from the left side to the right side of the chest on an axial CT scan. And when the sternum starts dipping below it, that is below the anterior costal line. And I'll give you some examples of that. But say perhaps in this diagram, about half of it, that point B is about halfway between A and C. So your Titanic index is going to end up 50%. Let's say the whole of the sternum was below the anterior costal line, then your Titanic index will be 100%. And let's say just that B was much, much further down, then your Titanic index might only be like 10%. So that is what we're going to measure. I'm going to show you some examples because it's probably the slightly weirdest one. And also you're going to measure on an axial, not sagittal views. But there's going to be lots of examples. So now I'm going to go over to the tool and take you through some examples.
Trial for Pectus. So we're going to provide you with this tool. It's an Excel spreadsheet. I'll go through it. There's some pictures at the front. There's a picture of all the measurements, but we'll go through them on real CT scans. These are the key measurements for the chest. The lower down one is the key measurements for the heart, because there's some cardiac compression indices. There's also something called the Titanic index. I provided a picture from the side, but it's actually easier to measure as a third step. So basically 3 steps to measuring. So I've got all the things that we're going to list here, and I'm going to put all the measurements in here, and once I've measured them, it's going to calculate it for you. And you can actually just cut and paste this at the end into your notes or whatever you want to do, and certainly it'll go into our restored database. Now, importantly, remember it says expiration and inspiration, so you want to know what phase it's in. And let's get cracking. So I'm going to show you some scans. So we take a scan. So what I first of all do is I just zoom it up to try and make it as big as possible so I can get as accurate a measurement as possible. I'm now going to go right from the top to the bottom. This is a patient we've actually operated on already. So I'm going to go down. I'm looking for the deepest point of dip. So here it comes, getting pretty deep. This is an NHS England accepted patient. Just having a look, and I think that's probably about the deepest point there. So, I'm looking here. It doesn't matter where the deepest point is, as long as it's the deepest point. So I'm going to now just put some lines on, and you may have some different software to measure, but it doesn't really matter. So I'm going to start putting some lines on. So now you're going to want to do some measurements from the front of this vertebral body. So my first line comes on here. There's also going to be a measure from the front, the most anterior piece of bony chest wall or cartilaginous chest wall, to the most anterior on the right-hand side. So I look for a piece of bone at the front, or where that piece of bone would be if it was in the middle. So it's not muscle and it's not fat, it's bone or cartilage, and that's a bit of bone or cartilage. Now I'm doing that one because we have to measure a dip depth as well. Next, I'm going to put the actual horizontal axis. This is, you measure the halo from this, so something you'll be very used to doing. But it's the internal diameter at the widest point is where you get your halo index. So I look up and down, and I try and find where is the biggest horizontal point. We got a lot of these tips from the CT scan radiologist from Phoenix in the Mayo, who's done 1,200 of these. He likes all these to be axial. He doesn't like you to angle them up or down. He likes axial measurements, so just be aware of that. So I put these 3 lines on first, and you'll see why that's helpful in a minute. I'm now going to start doing some of my measurements. So I'm going to take the deepest point right at the bottom. It doesn't have to be on bone, it's whatever the deepest point is, and to this line that I've already made. So the depth of this is 48. This we're calling the AP min, anterior posterior minimum depth, 48 millimeters. There's also an AP max. So we drop a line here, straight down here. And that's going to be quite useful for us. Now, in my software, some of it's in centimeters, some of it in millimeters, but you always want to do it in millimeters in the tool. So remember, that's got to be written in 104. I keep making that mistake, putting 10.4 in, getting it all horribly wrong. The next, there's a depth all the way from the bottom to the top, because it's something called the asymmetry index. So I'm going to go right from top to bottom. I just went parallel to that, because if I put the line one over the other, it deletes a line. So that's the maximum height of this left chest, and then I need to do the maximum height of the right chest. There we go. And then in some of the indices, we use the vertebral body as an important marker. So I'm going to put these on straight away as well. We actually need the vertical one for one of the measurements and a horizontal one for the other, weirdly. One's called the depression index, and one that needs it, and then the vertebral index, weirdly, needs a different axis. But I'm just going to put them on as well now. While I'm at it, I thought I might as well just get the angle of the sternum. This guy's is pretty bad, so There we go. So I've just done the angle as well, just while I'm here. So now I've got a load of our measurements. Oops, one I've forgotten is the dip. We're actually measuring the dip. The dip is from this line, from both the two heights, down to the anterior table at the deepest point. So in a vertical line. So we take it from the anterior border of the sternum. So it's not the skin and the subcutaneous tissue, it's either cartilage or bone for the dip. So now we've got our full set of measurements for step 1. I'm going to just minimize this a little bit and I can start tapping them in. So AP min, that's this one, 48.2. 48.2. Right. T, that's the transverse diameter, 266. So I go to three significant figures for everything. I think that's the restore mandated figure. So AP max, that's actually this one here, 104. 104. The AP vertebral diameter, that's this one, 26. That was measuring the vertebral body from front to back, 26.1. The reason they're together is because that works out the vertebral index. That's why it's in a, you might think, funny order. The dip, 42.1. That's the level of the dip, 42.1. The lateral vertebral diameter, 30.6. 30.6. And again, the dip and the lateral vertebral distance are together because they measure the depression index, and those two measure the vertebral index. You'll be able to see these formula. They're all up here if you forget them. Now, L is the left hemithorax, 153. 153. Right is the right hemithorax, 152. 152 measures the asymmetry index, which isn't much in this one. So that's all our measurements. The one other thing is the torsion angle, 34 degrees. And this is pointing to the right. So that's a right-sided tilt. So now we've got two more things. So we've done the first bit. The second bit is now the cardiac compression parameters. That's that stuff here. So what I tend to do is I change my view because I want to get the heart in as good as possible and as squashed, which is the most squashed view of the heart. This one, the heart isn't the world's most squashed because it's off to the right a bit. You know, you get worse, and I'll show you some other examples, but maybe that's about the most squashed. So we need a horizontal, a vertical, and a vertical. Now, the horizontal is easy. Now keep the line straight. You've just got to find the widest point of the heart, and for this, keeping it straight, but it would go about there. So that's the horizontal diameter of the heart. Now we've talked quite at length with the radiologist at the Mayo, and he's quite sort of particular about how he does the vertebral compression index of the heart, because officially it should be at the deepest point, which is kind of here, but there's hardly any atrium in it, is there? So this sort of thing, we want to get about a third of the atrium in this slice. So he recommends just make sure you get at least a third of the atrium in, and we'll just take it up to about there. I can get that out of the way if I'm not sure. So we're going to this narrowest point, got about a third of the atrium in at the least, so I wouldn't go to where there's hardly any atrium. That's where I'm going to go. He does agree that this is a little bit sort of by eye and experience, but we need to get a decent amount of atrium, and then this is the widest point of the ventricle, all vertical. So this is the if we just check here, just hit here, that's H is the horizontal axis, so that's 118, Then the minimum distance is there, 30.5. 30.7, sorry. And then P is 84.5. And that's going to work out 4.5. That's going to work out the cardiac compression index and the cardiac asymmetry index. And you can see it's all starting to self-populate. So you've got a Haller index of 5.5, correction index of 53%, which is how dipped is this compared to the whole depth. You can see this all in our CT manual. There's a vertebral index, a depression index. You've got the severes here. So again, this person's scoring very severe on all of these. Asymmetry, that's how different are the two sides of the chest, not at all different. And cardiac compression on this, very severe. Asymmetry index is bad as well. Now we just need one more thing to measure actually. It's the Titanic index. I think this is the thing that might confuse most people because remember what it is, it's what percentage of the sternum is dipped. Now if I were to go perhaps to a side-on view, then that's all right. If I were going to go to a side-on view, it would be at what stage does the sternum start to dip, and it's a percentage. So if that was in the middle, that's going to be a 50% Titanic index. We've been advised, and it is working better, not doing it on this view, because you can't tell when it starts to dip below the level of the ribs at the sides. So it's much easier to do it in your standard view. And so I always do it like this. So basically we've got point A, B, and C. Now how are we going to work these out? Well, luckily there's always a mark for what is the height in millimeters of the position of the image. So I'm at minus 464 at the moment, so I'm going to come down until I see the sternum. Let's have a look. There it is. Suddenly it turns up there. I'll go to the highest point. There you go, it's just disappearing now. Minus 537. So point A in mine has minuses, 537. Now I'm going to come down. Now, what you're looking for is at what point does that sternum start to dip away from this line? I'm not going to put that line in all the time, of course, but we're kind of looking, when does it suddenly take a dip? Ooh, it's certainly taking a dip there, isn't it? So let's go for, it does a fun little break there as well, doesn't it? So manubrium, sternum, maybe it suddenly really starts taking a dip. Certainly dip there. And again, it can, if it's below the sternal line from quite early, that's certainly starting to be below that line, then just do it from whatever line you like. So this is point B, minus 576, minus 576. And then you want to get the bottom of the ziffy sternum, not the bottom of the sternum, the last bit of bone. Sit there, that's the last bit of ziffy sternum, minus 697. Minus 697. So I have found some are in minuses as well as pluses. So the Titanic index there is 75%, because I kind of decided it was starting to dip relatively high up. Again, it's a bit of a feel one, but I think it was starting to dip just at about there. There was that space, wasn't there, on the scan where I sort of said it. That's so 75% of this sternum is dipped below that horizontal anterior sternal line. So that's how you do the Titanic index, and really that's it. I've talked quite a long time, but actually it's quite quick to get these. So now I've got a full load of scores ready to go. And then just on this, if you want to cut and paste that and put it in the notes, you're very welcome to. It's nice and quick. So I hope that was very helpful. The Titanic index, I think, is the ones that's going to maybe confuse people. Just remember it's the proportion of the whole sternum that's dipped below this anterior sternal line. The anterior sternal line being a point between the bones on one side compared to the bones on the other. So really, as soon as it dips below this line, it's dipping. Now, you can have 100%. If the whole manubrium and everything is below that anterior sternal line, you're going to get 100%. So don't be scared of saying the whole thing is dipped. So I'm going to show you a few other examples just for the video, just so that it just be a little learning point. This person's a bit severe, and it's also quite asymmetric. So I'll just do all the lines again. First of all, make it big as you can, because that'll make it as accurate as you can. And let's start drawing our lines. So one horizontal, which we're going to measure off that vertebral line. My next one is, what is the widest point? I won't put these in the table again. I'm just going to do it as an example of what I do. Keep that nice and straight. If these all start to overlap and get really annoying, I sometimes just move them up out the way. It's possible to do that. Next one, I'm going to do the bone on this side to the bone on that side, bone to bone. Right, now I'm going to start measuring the minimum AP diameter. So it's probably just at the bottom there. You see that dips around there. So I'm going to say it starts there. And it's not very big. 12 millimeters, poor girl. And then that was AP min. This is AP max to the vertebral body, anterior vertebral body line. Put that one for the left-hand side, this one for the right-hand side. Measure these vertebral bodies. And AP and lateral for the vertebral index and the depression index. And then measure the dip. So the dip's going to bone, so it doesn't have to be bone or cartilage, so it's going to go there. There's some cartilage, vertical. So while we're here, might as well do the torsion angle, which is huge for this lady. 42 to the right. So there's all our measurements done. And then the reason I put this one up is because of the heart. So here's looking at the cardiac compression index. How are we going to do this? Because that probably is the deepest point. Let's go up and down and make sure. So for this, I would say that's the. I sometimes just drop the line down so I can get it straight. That saves me having to drop a vertical line down here. So that's the width of the heart. And then where we're going to go for, so this is the right atrium here. It's a bit off center. So for the minimum depth of this heart, I think it's from here to about there. And then point P, the maximum depth, is going to be there. Nice and straight. So that's measured the cardiac parameters. So that was just another example. And just one more example. This is a really weird one. This is the weirdest one I've seen recently. I thought, how am I going to measure this? Because this is very right angled and they've got scoliosis and they've got damn metalwork everywhere. What a nightmare. So I think my take home for this was keep the all the lines straight. So I did the straight line here. Where is that vertebra? There it is. Get this from here to here. And then where's the deepest point? Well, the deepest point's over here. Crazy, hey? So, but I'll still measure it. It's still the minimum depth. That's going to be AP min. And AP max is going to have to be on this side, because there isn't a very big AP max on that side. There we go. And then height of the left chest is pretty tiny there. height of the right chest. For the vertebra, I actually scrolled down a bit. You don't have to do it from exactly the same level, and that vertebra was so wrecked that I went down to where I could actually see it away from the metalwork, because I was just never going to see anything. So I did the lateral, the AP and the lateral for the vertebral index and the depression index on a lower level. Just in this person, made that decision myself. And then just got the dip to do, and weirdly, dip was quite small because she's so strangely asymmetrical. Not perfect that, but yeah, the dip's tiny in this person, strangely. So that's how I've measured this one. But the most difficult bit on this person is what you're going to do with the heart. So again, I just thought, well, the horizontal width is from there to about there. Should really have that straight, shouldn't we? So dropping a line. Now where's the narrowest point? Because the narrowest point, where is it? Where is it? So I thought, well, narrowest point. It's also of the heart. So if you've got a contrast CT, you can use the chamber, which is nice. So I put it about there. So that was the narrowest point in the atrium. And then the wider part, I'd put it maybe about there. So we're trying to get this minimum point generally in the atrium, but the dip's over here. So that would be the height in the atrium. That's what I decided. It probably is quite one of those difficult ones. And then also for the Titanic index, what are you going to do? Well, to me, it was just, when does this sternum dip? And as I come down, fairly flat, really, isn't it? So maybe I'd say it dips about there. So I take that as point B. So you do get some difficult ones. I hope you've seen that was fairly quick. Obviously, you do inspiration and expiration, but it's fairly quick. I hope you find it easy. If you've got any problems, do text. We might put some difficult ones up in the chat if people want advice. I think possibly this is more difficult than that, potentially. But I hope this has been helpful and not scared you off too much. And I certainly recommend doing all these scores as soon as you see the scans in clinic. That's what I do, and I put it in the letter. Thanks a lot.